Respected discussants, dear audience, Assalamu alaikum. I am Dr. Muhammad Azharul Islam, working in NICBD, and a very good morning to all of you. This is my best effort on an uneven road. My patient is a 50-year male, non-diabetic normotensive, came to us with CCS3 for chest pain on optimum guideline-directed medical treatment, but he is still symptomatic. Then his ECG shows that ST segment changes in inferior lateral leads, and echo showed there is no regional all motion abnormality with LBF 60%. Look, this is the track I have traveled through. This is the loop at the right subclavian. And this is the angiographic view of right coronary system. And you should appreciate that the patient has got significant disease at his mid RCA and distal segment. And there is an excellent finding that you look that the LAD is originating from right coronary sinus. This is the view of left coronary system, and you should appreciate the left main distal has got critical disease, and it seems to be sarc ostium, and the ramus ostium is normal, and there is a tiny LED-like vessel originating from left main. So, and we did the syntax score, and his syntax score was 16. Then we planned for PCI. We started with the right coronary system. We wired the vessel. Initially, the wire was kept on the PDA, followed by we kept another wire to the, we did pre-dilatation with the 2.515 balloon. Then we wired the PLV. We did IVAS on the right side because we had in mind that the patient might have a dissection on its mid segment if you look the angiogram, and we find that the dissection the patient has. And look at the dia, it is almost 5 at the mid right coronary artery. This is the dia of the distal RCA and the mid RCA. Distal RCA is approximately 3.3, 3.6, and mid for 5.4, 5.3. So we planned for 2 stents as the dia is mismatched, and distally we put a 3.5 28 millimeter stent with overlapping a 434 millimeter proximal stent. We did post dilatation with 4.58 millimeter NC balloon, and this is the final view with good 3V flow and good angiographic outcome of right coronary system. Then we proceed with the left. We engaged left main with a 6 French EVU. We wired both the vessel, and we did pre-dilatation with 2.8 NC balloon. After pre-dilatation, we did the IVAS, and if you look at the IVAS run, you should appreciate that the patient has got critical disease at distal left main, and the sarc ostium as well as the ramus is free of disease. So we clearly planned for a single stent strategy. This is left main ostium, left main mid, and left main distal. Distal has got critical disease with a significant plaque burden, that is 73%. This is point of confluence, and proximal ramus is totally free of disease. So we put a 412 stent from left main to ramus. We did POT with 4.58 balloon. After POT, look at the ostium of the sarc. Are you convinced with the sarc ostium? I am not so. The patient had chest pain, ECG was getting changes on the monitor, and if you look, the angiographically it is more than 75%. So we recross the sarc with a hydrophilic wire. It was filter FC, and we sequentially did balloon dilatation. Initially, it was 2.8 and followed by 2.58 millimeter NC balloon. And finally, we did KVI with a 410 at the left main to ramus and 2.510 millimeter NC balloon. And we did finally POT with 4.58 millimeter NC balloon. This is the post IVAS. It is the distal MSA. If you look at the MSA, it is 9.3. It's good. And at left main, it is 10.4. 7.4 MSA. And we did OCT, basically to look what we did with the ostium of the sarc. This is left main proximal, its MSE is 10.8. This is the OCT run, and you should appreciate that the while expanded, while opposed stand to the left main. And if you look at this 3D view, there is no start of the stent is occupying the sarc ostium. This is the ostium of the sarc. At a still picture, even you can appreciate that there is no start. So this is the final view. I think you are happy with this angiographic final view with the ostium of the sarc. So what is the recommendation? As all you know, with left main bifurcation, the imaging has got class 2A recommendation. And if you look some trial like Illumine 4, October trial, and some meta-analysis, it already been established that reduced risk of cardiovascular death and major adverse cardiac events such as myocardial infarction, target lesion revascularization, and stent thrombosis with image-guided PCI. So my take-home message is main vessel stenting with provisional sideburns treatment is recommended as the preferred technique for the majority of bifurcation lesions. Kissing balloon inflation may be used when an angiographically significant, that is more than 75% or less than 3 TB flow ostial side branch lesion remains after main branch stenting. And when an side branch stent become necessary, the provisional stenting, T-stent or TAP or internal mini crush or pull-out is the preferred technique. And FFR may be used for evaluating left main coronary artery bifurcation lesion in stable patients. And IVAS and OCT may be of particular value in guiding bifurcation treatment and are recommended for left main bifurcation treatment. So my conclusion is revascularization of a vessel only is not our desire, but optimum revascularization is our ultimate goal. I would like to acknowledge my mentor, Professor Mir Jamaluddin Sir, Director NSCBD. And let's say a very good happy Labor Day, because today is Labor Day, the person who are contributing to a beautiful world. So thank you all. Thank you for patience hearing.